Midline is marked, then the breast meridian is marked in the right side. Usually the breast meridian is middle of the breast. Actually, it need not cross the nipple. In this case, it's just crossing the nipple, but a lot of times it might be lateral to the nipple or medial to the nipple. So it is basically a midline of the breast. So same breast meridian is replicated in the other side also. So that's very important because if you want a symmetrical breast, the one side you have to take it like a control and you have to use the same measurement in the other side so that both the sides look symmetrical. Here if you see it's not crossing the nipple. Mark the intramammary fold, anterior axillary line. I don't want my scar to cross the axillary line as much as possible. Sometimes if the tissues are more, we extend the scar. I just curve the scar closer to the breast so that scar won't be visible when they wear a bra. So now in this case, we are doing a fat transfer also. I mark the liposuction area also. The new nipple position, usually I keep 1 centimeter below the inframammary fold. For me, it works in most of my cases because going with a 9 centimeter below the meridian or the mid humerus point, those things might not suit in most of our Indian patients with a huge breast. So I always go with the 1 centimeter below the inframammary fold. That works all the time. So I check the measurements in both the sides and so make sure that both in the same line. So in this case, it's 22.5 centimeter. I plan to keep my new nipple position. So existing is 29 and 30. So now I twist the breast. Basically, you have to understand why we are twisting the breast. This part of the skin has to come down and sit in the medial and lateral pillars. So I twist the breast and I plan my excision lines. So this one I'll decide according to the what my planned size of the cup size. So here I kept 8 centimeter because I planned for the D cup size because she wants a good volume, only the lift she wants. So if you want the C cup size, I'll go 7. If I want the E cup size, I'll go 9. Now I am connecting the medial and lateral pillars to the inframammary fold. So as I said, my medial extension should not cross. So the medial end of my inframammary scar will be 2 centimeter from the midline. If you go closer, sometime when you're correcting the dog ear, it will cross the midline so that you make sure that your medial end of the inframammary scar should be 2 centimeter from the midline. Lateral end, as I said, I'll limit my lateral extent of the scar up to the anterior axillary line if needed. I'll curve the scar, not extend the scar laterally. The superior medial pedicle is marked. Initially, I used the supermedial frag with a base of 8 centimeter. Now, after listening to one of my close friend, Dr. Jayanta Bain, and a few other articles, after I read the articles, I mark the perforators now, and I keep at least 2 perforators in the flap.
Doing the vascular marking to see if this pedicle, 8 centimeter pedicle, contains any perforators or not. So we will be just going through this line. So we travel from medial to lateral. So we can hear almost near the breast meridian, we can find a good perforator. So we mark it here. Then we will go further. So this is another perforator.
This is a modification what we have done in our practice. This is a triple dermal pedicle flap design. The lower flap is 3 centimeter in width and 2 centimeter in height, and the upper flaps are 1.5 centimeter from the T-junction and 2 centimeter in dimension. These two dermal flaps are inserted lateral to the lower inverted U flap. So this is the place where those two flaps get inserted. When you are relieving the tension by inserting these flaps in this region, so T junction tension will be relieved. This is the deepithelialized flaps. So after painting and draping, the important landmark points are marked with the epidermal cuts. Even the methylene blue marks disappear. Usually this cuts gives us a complete idea where to cut and how to raise the pedicle and so that we don't get confused. Using a cookie cutter according to the size of the breast, we cut the areola, then we started raising the pedicle. So the deepithelialization is very important point. So we use the 200 ml of saline and 2% lignocaine, 30 ml and adrenaline 1 ampule. The injection plane also very important. If you are injecting in the wrong planes, your elevation will be difficult. So we finish the deepithelialization where we have planned to raise the dermal pedicles. The same dermal pedicle area also deepithelialize. After the deepithelialization, this is a look of the breast, and you can see the deepithelialized pedicle part, and deepithelialized the dermal flaps also seen in the right and left side, and the inferior also you can notice the dermal flaps deepithelialized. If you see the lateral pillar side, we kept one more flap, it's a deepithelialized flap. What we have seen is when we do the dermal flaps to avoid the T-junction necrosis, we started seeing small wound gaping and necrosis in the vertical line. So now we don't want too much pressure in the vertical line as well. So we don't want to take a epidermal bites and damage the skin a lot during the suturing. So now we keep this vertical strip of dermis so that we don't go and take the very closer bites in the epidermal region, so that your superficial necrosis has gone down after doing this method. Even the incision areas, we inject adrenaline lignocaine solution so that bleeding will be less. Now all the incisions were made and deepened. The pedicle is now raised. So you keep your blade vertically, so don't bevel it in this region so that you don't want to compromise the blood supply. So use the blade as much as possible in the pedicle raising. So avoid the diathermy and diathermy burn. Overuse of diathermy might lead on to a necrosis of the nipple areola. So keep the thickness at least 5 centimeter in the tip of the flap, and you can progressively increase the thickness, and you have to go up to the pectoral fascia. Now the flaps are raised. These dermal pedicles are really useful in avoiding the tension in the T-junction. After raising the flap and dermal flaps, the excision started. The excision has to go up to the pectoral fascia if it is a breast reduction. If it's a lift, only excise the skin, don't excise the glandular element. We need to do a little bit of excision to make our skin closure easier. Though the breast lift alone, sometimes we need to excise a little bit of tissue that makes the breast lift easier. So in this case, it's a breast reduction, so we completely remove the breast tissues from the pectoral fascia. When you are excising the gland below the lateral pillars, don't thin the lateral flap. So keep the lateral flap little thicker so that ecchymosis will be less and healing will be faster. This is the dermal pedicle anchoring I was speaking in the beginning. So when you anchor the dermal pedicle little lateral to the T-junction, the T-junction tension will goes down a lot. So both the sides the dermal pedicles are anchored. So now, as I said, nowadays we use even the lateral pillar, we keep a vertical dermal strip, but in this case I have not done that. Now if you see, the tension in the T-junction has gone down considerably. Then we complete this with the trial clip stitch. And I don't use a keyhole pattern. I am preferring this method of planning my areola later. So that gives a lot of control over my keeping the areola level same way in both the sides, because I feel the keyhole pattern sometimes we lose the control, and at the end of the surgery sometimes there is a discrepancy difficult to handle. So we use this method so that we can adjust a little here and there when we take the areola out. This is the final suture line. I use 20 vicryl continuous sutures for the subcutaneous and 30 vicryl and 50 ethylene for the areola.